Good evening, madam.
Am I audible?
Yeah. Good evening, ma'am. Dr. Shant Kumar
Good
here.
evening. Yes, good evening.
Good evening, madam. Rajendra.
Good evening, Rajendra.
Hi, Shant Kumar.
Rajendra, good evening.
Again, Papa has conference, you should not come out, okay? Okay, don't just have fun inside. Okay? Rajendra, ಎಷ್ಟು ಹೋಗಿದೆ?
1 hour.
ನೀನ್ ಪಾಠ
Hi, Dr. Suresh. This is Rahul here.
Hello.
Yeah, hi. Can you test your mic and everything if all working good?
Hi, this is Dr. Prashant Kesri.
Yes, sir.
Can you hear me?
Yes, sir. Dr. Prashant Kesri, sir. I can hear you.
Can I share the slide and see?
Yes, sir. Sure.
You need to allow me because I'm unable to share the content.
1 minute, sir.
Hi, Prashant.
Hi.
Good evening.
Good evening. Good evening.
Good evening.
Good morning, madam. Good morning, everybody.
Yeah, good morning, Purani.
Rajendra, sorry, good
Good
evening.
evening.
Good evening.
Good evening. Good evening.
Madam, good evening. Kesari sir, good evening. Who is there from GHA side?
Hi, this is Rahul here.
Hi, Rahul.
Yeah.
Rahul, can I just make sure that participants' audios are switched off? Because a lot of times we have participants speaking.
Okay.
Okay, just
Sure,
make
sure.
sure that the participant side, not from the faculty, participants from their side. Let
No,
them
so
know.
we have not added the participant here in the Zoom. They
No,
are
not right now. During the process of when we are going to go for the final webinar, we feel that sometimes there are a lot of background noise which comes from the delegates who join in.
Yeah. So no, so to delegates, we have not shared the Zoom link. They will be watching this from our platform. So they will be not here in the Zoom.
Oh, they are not going to hear, is it?
No.
Because Sumana had shared a link, so which we have tried to share to them actually.
Zoom link, not the Zoom one, right? The other website link it is, right?
No, Zoom link it was.
Zoom link also. Okay.
Yeah.
Okay, fine.
I think you'll wait for some more time. Okay. Can you know how many people are logged in?
Here in the Zoom, we have 11 people.
No, not here. From the delegate side.
That is like right now around 50 people has done. I mean, we
Okay,
have
we'll just
total
wait for
more than
another
100.
few minutes and then we'll start.
Yeah, like 7:05 we can start around that.
7:35.
7:35.
35. Yeah. Fine.
5 minutes we can wait.
Yeah. Hello, sir. Good evening. Kesari, sir, you are there?
I think he is unmute.
Hello.
Good evening, sir.
I'm
Welcome.
there. Good evening, Prashant. Good evening, Shantu. I think sharing the content is not allowed by the host, so that.
No, you can all. Everybody at the moment who are all logged in, they're all hosts, so they can always share. There should not be any problem actually.
No, it's not happening. That's what. See, you can't start screen share while the other participant is sharing.
Yeah, it's not yet allowed yet.
Okay.
We have allowed the screen sharing. Can you retry now?
Yeah.
I think everybody can just do a trial once.
No, it's not coming.
I'll just try
you
once.
You can't start. Yeah.
Yeah. Is this your screen, sir?
No,
somebody is sharing the
shared,
screen.
Yeah.
Who's sharing this?
You're using Rahul's screen. Rahul's screen.
Yeah, I was just testing that. Now you guys try that.
I will try once.
Yes, please.
Can you see my screen?
Yes.
Yeah, we can see the screen.
Okay, I'll stop my share. Sir, Kesari sir, noಡ್ತೀರಾ ನೀವು ಒಂದ್ಸಲಿ?
I will try now. I am unable to start the video also.
Yeah, I am unable to share the screen now.
Yeah, now I am unable. Yeah.
No, once again, I think if somebody else is sharing, then others
then,
cannot.
then it won't
stops,
happen. That it won't happen. Yeah. One after the other.
Yeah, Rajendra is coming. Yeah.
Should be okay.
Shall I try once? Rahul, I think you need
Yes,
to enable
yes,
my
doctor.
video.
You can try now. You can try now. It's open for everyone.
Yeah. I'm sharing my screen now.
Prabha madam, good evening. You are there, madam? Madam was there.
Yeah. Can you see my screen?
Yes,
Yeah,
doctor.
yeah.
We can see.
Now, yeah, visible.
Yeah. Oh, yes.
One request to all the speakers, please stick to time.
Hi, Madhu.
Hi.
Good evening, Madhu sir. Good evening, Shantu.
Yeah, good evening.
Good evening, Rajendra.
Good evening, sir.
Yeah, about to start. About to start.
Suresh, you are there?
Yes, sir. I'm here, sir.
Okay, Suresh. Yeah.
Okay.
I think everybody has joined. Madam had joined. I think she left, I guess.
Madam is there. Madam is there, Prashant.
I'm
she was
there.
here.
No,
Okay, okay.
suddenly something happened, so I locked out and again joined.
Yeah, because I saw your name was missing. Initially, you were there. Madam, do you
Yeah.
want to try your screen
Yes.
sharing?
Yeah.
You want me to? I
Yes,
will.
yes. Just do a trial once, ma'am.
Okay. I think it's there.
Yeah, it is there, ma'am.
You want me to scroll through everything? Yeah, it is there. You want me to minimize it now?
No, that's fine, sir. Madam,
Stop
screen
share?
share is happening. We just wanted to know whether it's happening or not.
Yeah, I'll stop sharing.
Yes, yes, ma'am. Yes, sir. You're joining now, sir. Ashok, sir, you want to try your screen sharing? I just want to make sure that there are no issues later. Hi, Aditya.
Hello, sir.
Good evening, Aditya. Welcome.
Good evening, sir.
Shall we start, sir? Everybody is fine?
Did you guys see my screen? Was it visible?
Yeah,
No,
yeah,
no, sir.
visible,
It
sir.
wasn't.
Yes.
It was not. It was not.
It was visible.
Hi, Dr. Rahul here. Can we wait for another 2-3 minutes? Some participants are still joining.
Yeah,
Just
sure.
2 to 3 minutes. Yeah.
Rahul, just let us know before you go online.
Sure. Okay.
Miss Anita is there. Will you just let her in? I wanted to talk to her.
Who, doctor?
Miss Anita from your team, from your GHA.
Yeah,
Guys,
just let me.
I think you better
can you
get
see now
through
my screen?
as a host.
Sir, your screen is visible, sir. Ashok, sir.
First class, yeah.
It is
thanks.
visible.
Okay. Hi, Madhu. You muted yourself.
Sir, did you
Hi, Dr. Ashok.
So did you share your screen?
Yeah, I did. And people said they could see.
Can you check this? I shared my screen. That's okay.
Yes. We can see
Yeah,
you, sir. We
visible.
can see you.
Yeah.
We can see you. We can see you. Rahul?
Yes, doctor.
once you say yes, we'll be going.
Yeah, sure.
Miss Anita is there. She was not sure whether she'll be joining or not.
Doctor, I'm back. I'm here.
So you will be starting. You'll be the first person to speak.
No, doctor, I think it's been briefed to Dr. Suresh.
Yes.
because
No,
I'm
that's fine.
busy.
That's fine. Suresh will start the proceedings.
Right, doctor. I'm in a noisy place, so I'll mute myself.
Sure.
And Prashant,
Yes, sir.
so the who are the target audience? Basically, the delegates, or there are other people?
I think
It will not go more than 225.
Ms. Anita, can you just tell us about target audience? We're segregated to various groups actually. GHA has been kind of actively doing this, reaching out to various people.
Yes, doctor. This is actually an open webinar. So we have allowed people to register and come in, but by marketing the course, so people know that this is regarding the course that we are going to do. So it is from plastic surgeons to oncosurgeons to, head and neck and all the other, mainly which we want for, plastic surgery and things like that. So we have most surgeons we have invited, doctor. So on the platform, the number of people have joined in already. So they will be all joining in from the platform. This is only for speakers, doctor.
I think we will keep it open. Let's not try to cut down any of the topics.
About to start in 2 minutes. Perfect. Anything is right? Anything else?
Doctor, we are good to start. So the countdown has started.
Hello, good evening, everybody. I am myself, Dr. Suresh K. I am working as a junior consultant in HCG Hospital, Bengaluru. Welcome you all to the introductory webinar of second International Reconstructive Surgery, Head, Neck and Skull-Based Surgery cadaveric courses. And mainly it is organized by the Global Healthcare Academy. I brief about Global Healthcare Academy. It is mainly instituted with the mission to develop competent and compassionate human resources for the healthcare sector, and it promotes innovative solutions and enterprises in healthcare. Its purpose is main purpose is to bridge the skill and knowledge gap between formal education and needs to the healthcare industry, and it has a distinguishing feature it provides intense collaboration at every stage between practitioners and tutors, like from conception and the formulation of training programs, and mainly enlisting the faculty with sufficient work experience, and towards the case-based learning from a real life situation and practice-oriented learning methodologies. And it is the Global Healthcare Academy is led, managed, and advised by reputed doctors and healthcare professionals. With this brief about regarding the Global Healthcare Academy, I would like to hand over to the Dr. Prashant Pauranik, our course director, for giving a welcome note. Dr. Prashant sir, you can give a welcome note.
Thanks, Suresh. I will welcome you all again for the second International Reconstructive Surgery, Head, Neck and Skull-Based Surgery cadaveric dissection courses. And from the reconstructive surgery module, we are having this introductory webinar. We had our first flap dissection course in November last year, and it was very well received by all the delegates, and there was request for more such courses. And hence we planned for the second flap dissection course, which is on March 28th and 29 at MS Ramaya Skill Lab. And as we all know, COVID has restricted access to in-person conferences, correspondences, and at places, workforce has been channelized to COVID care. So the clinical exposure is found wanting. And this comprehensive flap dissection course has been carefully crafted so that we cater to the young and also in practice plastic and reconstructive surgeons. So we have a gamut of faculty for this course who are very well experienced with in-depth knowledge of nuances of microsurgery, and who will share their knowledge and make this flap dissection course an enriching experience for all the delegates. And all the moderators and the speakers of today's introductory webinar will be faculty at the flap dissection course. And it will be a great event that will happen on March 28th and 29th. I request Dr. Suresh, our junior consultant at HCG, to start the webinar proceedings.
Thank you, sir. I take this opportunity to introduce other coordinators of the course, Dr. Shanta Kumar S. and Dr. Aditya Patil. And Dr. Shanta Kumar sir is presently providing his services as Associate Professor in the Department of Plastic Surgery in MS Ramaiah. And Dr. Aditya Patil is working as a consultant plastic surgery in Sagar Hospital, also visiting consultant to HCG Hospital. Now I request Dr. Shanta Kumar sir to further carry forward this session with introduction of our first speaker, Dr. Prashant Kesari.
Okay. Good evening, everybody. Am I audible?
Yes, sir.
Hello?
Yes, sir, you are audible.
Yeah, okay. Yeah, good evening. Welcome to the second international course webinar. And today's our first speaker is Dr. Prashant Kesari. He is a renowned plastic surgeon in Bangalore. He is presently working in as a senior consultant at Naipunya Aesthetic Clinic, Bangalore. Dr. Prashant Kesari has done his plastic surgical training from Mumbai prestigious institute Sion Hospital, and is also has advanced fellowship in cosmetic and laser surgery in his credentials. And he regularly shares his expertise by giving talks in conferences and plastic surgery meets. His main motto is to understand the patient's need and use his surgical expertise to give a satisfactory results to the patients. He has a special expertise in liposuction, body sculpturing, and procedures, having performed many of hundreds of the patients on these things and giving a good satisfactory results. And today he is going to talk about the planning a free flap reconstruction. So I think one of the nice topics you should listen to him. Dr. Prashant?
Yeah.
Dr. Prashant, please take over. Yeah.
Yeah. Thank you, Shanto, for nice introduction. Is my screen visible?
Yeah, visible, Prashant, visible.
Good evening, everybody. Thanks for an opportunity to present this paper. I want to share a little of my experience in microvascular reconstruction. I've been doing microvascular reconstruction in Bangalore from 2009, and the difference or what it was different for me is that it's not only based out of an institution, but it's I also do freelance plastic surgery practice. So I end up doing microvascular surgery in a freelance setup, that is in corporate hospitals, mid-segment hospitals, and nursing homes also. And we are a team of three. Dr. Pradeep and Dr. Samir are with me, and we operate as Naipunya Plastic Surgery team. And I would like to say to all my younger colleagues that you should plan a free flap with the end in mind. What is the core objective of the flap you want to achieve? So if you are reconstructing a tongue, you should set priorities, whether the speech, mobility of the tongue, and minimal scars on the face. These are the objectives. And if he is a young patient going for radiation, making the flap sensate has a little advantage. And if you're reconstructing a palate of a young lady and going on to the soft palate, achieving oropharyngeal competence and speech becomes of ultimate concern. And avoiding scars on the face will have a lot of psychological benefits, which we often know. And if we are doing a fibula reconstruction, please plan in such a way that occlusion, mouth opening, and proper dental implants, which will be done only after, say, 6 months, will be like fitted properly in the flap we have harvested and reconstructed. If we don't keep this in mind, and it will invite additional procedures so that the patient will be burdened with it. So when you are planning any free flap, please keep the end point in mind and then plan your flap and execute it. And we have 3D model and it has dumbed down the process of flap planning. Actually, you get where to cut, how many plates to put, how many screws to put, everything you can do it pre-operatively. So it's a very, very important thing to make use of it. And unlike many of my colleagues, I don't do bench osteotomies, but I do it when it is still attached. And each person has the way of doing CAD/CAM and other image-guided 3D printed modules, pre-bent plates. All these things are pretty routine now. So I would like to address planning the free flap under these headings. In plan P, you plan your paddle properly. You plan length of the pedicle, how much it should be, whether the flap you are planning will actually reach to the most ideal spot of anastomosis, and where all you are going to anastomose, what artery, what vein, and is it patent, no atherosclerosis. Like, plan for a good night's sleep. You execute the flap in such a way that you can go home and sleep well. Trust me, this is very, very important. If anything can be done to secure a good night's sleep, please do it. And you are as good as your team. So build a very good team and plan for failures. If this fails, what is the plan B? And please involve the family, because that will take out a lot of stress and they're the ones who will stay. And please plan for your lunch, and more importantly, for long-term results. And you plan for accessory procedures, maybe dental implants or revisions or thinning of the flap. You plan when you're planning the flap. And please plan your flaps in partnership with the oncosurgeons or whoever is doing the resection, and plan it with a free spirit and free hand. Here is a patient where we discussed with him, he did not want teeth, but a good lip and competence. So we ended up doing radial artery with Palmary sling. Here is another one, similar defect, much elder in age, but he wanted teeth. And we had to do a double paddle fibula. And here is another patient, very much wanted to do fibula with double paddle, but we could not because his leg was not providing enough of skin. So we ended up doing ALT. Maybe we'll put a bone at a later stage, and we could achieve reasonable amount of competence. So each defect will demand a particular flap. It's important for us to know which flap fits the patient's need and the defect and our expertise. So when I was attending flap dissection courses during my residency, I was told, you be master of 6 flaps. If you're going on an island and you want to take 6 flaps with you and nothing else, you learn these flaps thoroughly and you become master of those flaps. Then you can manage most of the defects. Truly, it still holds good that few of the flaps which you have learned, if we push the limits and boundaries, it will fit most of the defects. Here is a fibula with a supramalleolar extension, which we planned and executed for tongue, achieving better tongue mobility, as well as floor of mouth and sulcus. And when the defects are expanded, we need to assess the defect properly, because many a times, like the bigger looking defects and gross tech looking defects are actually easier to plan and execute. And whenever there is an expansion like this, please plan for filling the dead space. It may look a little bulky, but use soft tissue to fill it so that there is no infection, healing is fast. Anytime you can later, once everything is through, you can debulk. And very, very important to shave the patient and examine properly, bimanual examination, everything, no shortcuts, because many times such preoperative examinations will be deceptive and you need to plan for this. And these are all in ideal case scenario, you get to see the patient, evaluate the patient, and discuss with the onco team and discuss with the patient, and then proceed. Many times what happens is all these things do not exist. What kind of flap you have to plan depends on where you're doing, why you're doing, when you're doing, who is the oncosurgeon, and what exactly will be there. many times post-radiation, free flap reconstructions, few things you need to keep in mind is skin requirement will be more than you anticipate always. And vessels will be fried and you need to spend a lot of time in dissecting. And even after doing a good job, rehab will not be easy. So you need to plan for a good rehab beforehand. You need to motivate the patient. Otherwise, even doing a good fibula like this will have one finger mouth opening, which is as good as a failure. And another thing is, it depends on how convinced your team is and the patient is. See, the upper three photographs are of a lady who underwent PMMC. Ideal would have been a fibula with skin graft, and lower ones is a patient with post-CABG but underwent fibula with dental implants. So it's very, very important to educate our patients and educate team in which we work to show the benefits of microvascular surgery. And another thing that happens is, how much time do you get to plan? I've intentionally kept the screenshot because this patient's photograph was sent the previous night, 7:10, and the surgery was next day in the morning. And once you go, there is defect everywhere. We did not even know whether it was resectable or not. And frozen section, many a times, is a double-edged sword. Most often, it works against plastic surgeons. And this is the same patient reconstructed with a double paddle ALT chimeric flap. And sometimes you get so much time to plan that we have increase in the size of the defect and increase in the tumor, and we end up doing latissimus dorsi, anastomose to neck, and covered part of the defect and the dura which was open with a transposition flap. So the scenarios in freelance practice are highly variable. You don't have a set operation theater team, nurse. So it's very important to build a team from light to cautery to fissure burrs to saw. Everything you need to plan in advance. And thanks to my training in Sion Hospital, that was very well covered. And in this patient, we did not plan an ALT because the skin had some DLE and other precancerous genetic disease. So, and especially when we are doing recurrent diseases like this, please plan for a tile. Like how we do it in posterior interosseous artery or reversal, tile comes to our safety many a times. Like in this patient with dura open, and if the tile was not there, we could not have revised and salvaged after draining of a hematoma. Please plan B. Failures can occur in 100 flap or 1000 flap or 10,000 flap. So this is a failure at 12th day anterolateral thigh flap for covering the temporal fossa and skull base. And it's very important to stay humble, which we can learn from our Professor Prabha Yadav madam. And it's very important to sometimes put your foot down and say, no, this needs a free flap. Like this lesion, which will do better with the vastus lateralis or anterolateral thigh flap. And we were forced to do reversal, and then we ended up doing a vastus lateralis with skin grafting because patient was very bulky. And many a times we need to prepare for collateral damage. In this patient, there is paramedian necrosis of the skin, which luckily we could manage with just secondary intention. There are instances where neck skin has necrosed. So it's very important for us to plan our anastomosis and secure it as away as other incisions possible. And please plan for possible recurrences. Good that we had such an extra flap that this patient was undergoing 4th resection and reconstruction. So the laxity of flap allowed us to just advance it and close. So please plan your flap, plan your paddle, length of the pedicle, anastomosis. Do everything that ensures that you have a good night's sleep and you develop a good team. And please involve the family, because microvascular surgery is pretty stressful on you and your family also. Please plan for lunch of your team members, yourself, and focus on long-term results and be ready for accessory procedures and make a good partnership with the reconstructive surgery, resection team, and the patient and the relatives. Very, very important. So I wish all of you can plan your free flaps without fear, without restrictions, without ego or emotions and economic pressures. And I thank all my team members for doing whatever little work we are doing in the field of microvascular reconstruction, along with other verticals of plastic surgery. And Rome was never built in a day, but free flaps will have to be done in limited time. So I thank all the organizers for giving me this opportunity. Thank you, one and all.
Thank you, Prashant sir, for highlighting the importance of planning in the free flap surgery, and it is will be very helpful for young plastic surgeons. And now I'll introduce Dr. Rajendra Ji. He is presently working as a lead consultant in Sakra World Health Hospital, and he did his MCH from prestigious Bangalore Medical College. And he also did the fellowship in reconstructive surgery from Tata Memorial Hospital, and also had training in hand and brachial plexus along with microsurgery from prestigious Ganga Hospital. And is well known for establishment of a unit for cancer care and microvascular surgery in a Baptist hospital in Bangalore. And he is also did a fellowship programs from Korea and Japan in lymphatic surgeries and super microsurgery, and also cosmetic surgeries. Now I request, and you'll be presenting regarding the armamentarium of free flaps in reconstruction. Now I request Dr. Rajendra Ji sir to carry on the presentation.
Hello. I'm not able to share the screen. Yes. Good evening, everybody. Today I'm talking on armamentarium of a free flaps in a head and neck reconstruction. This is I am giving just overview what all the flaps are there, the in detail planning, pre-op planning, harvesting and all taken in the flap dissection course. So head and neck cancer is a common condition, and a reconstruction of head and neck is a complex and challenging with regard to the function and aesthetics. An ideal reconstruction should mimic the missing tissue with regard to the structure, geometry, and the tissue characters. So the goal of onco reconstruction in head and neck is to repair the defect primarily, normal wound healing, preserve the function, and achieve the acceptable cosmesis. The evaluation of a defect, including its size, shape, geometry, and relationship to other available recipient vessels, is very important, and a strategic approach to flap selection and design should be taken in order to reconstruct the oral defect accurately and restore the patient to the preoperative function and aesthetic status. It's a usually is a very complex defects are very complex. Many a times local flaps are unavailable or inadequate, or there is many a times is a radiation. So free flap microvascular transfer is a only option available in most of the head and neck reconstructions. So this microvascular free flap, it avoids generally two-stage procedures most of the times, and the freedom for a flap to insert to achieve the better outcome, more donor sites with a minimal donor site morbidity, and a single flap that meets all the reconstructive demands with regard to size, thickness, pliability, tissue bulk, and the skin turgor. The commonly used free flaps in head and neck reconstruction are for a bone reconstruction. Most workhorse flap is a fibula. For some cases, iliacrus, DCIA, and a scapular parascapular osteocutaneous flap. And for a soft tissue reconstruction, ALT and radial forearm are the workhorse, and other flaps are medial sural artery perforator flap, lateral arm flap, and a visceral flap like a pre-jejunum for a pharynx reconstructions. Fibula flap, this is a workhorse flap, and it is taken as an osteocutaneous or only bone flap. The length of a bone and consistent of blood supply and the relative ease of harvest make this donor one as the most useful when osseous reconstruction is required. The usual common indications are mandible and maxilla reconstruction. The blood supply for a fibula is both endosteal, where there is a direct blood supply to the bone from the peroneal artery, or a periosteal blood supply. And it's the main blood supply is from the peroneal artery. The caliber of is generally is around 1.5 to 4 millimeter, and it arises from the tibio-femoral tibio-peroneal trunk. And usually the epiphysis and fibular head is supplied by the full length of the fibula is supplied by the peroneal, and epiphysis and fibular head is supplied by the branch of an anterior tibial artery. And usually it gives a septocutaneous and or musculocutaneous branches to the skin paddle. The usually pedicle length is short, but you can increase the pedicle length by taking a paddle very distally. And around 22 to 26 centimeter of a vascular fibula is harvested, and upper and a lower 6 centimeter fibula are spared, and proximal 6 centimeter to prevent a common peroneal nerve injury, and distal 6 centimeter to maintain the ankle stability. The advantages of a fibula is the longest bone, and segmental perforators allow for a closing osteotomy and adequate stock of the implants. Adequate bone stock for implant dental implants. The extent of skin paddle and flap is almost shown in this picture, and we can take most of the lateral half of the leg as a skin paddle, and some 2 mm cuff of muscle is left over the bone to maintain the periosteal blood supply. The next flap, bony flap, is a deep circumflex iliac flap, DCIA, and usually it is taken bone along with the periosteum and iliac muscle and a skin paddle. It can be harvested with or without skin paddle, and the pedicle is from deep circumflex. The artery is a deep circumflex iliac artery, which arises from external iliac artery. Usually it arises at the junction of external iliac and femoral, and sometimes it commonly arises from the both SCIA and DCIA arise commonly and then divide. And usually the bone length we get in this is around 12 to 16 centimeter long, and it provides a large segment of cancellous bone to and the width and the length is around 15 centimeter long and 6 centimeter wide. Bone can be harvested, and usually it is used for the anterior and angle of the mandible reconstructions, because it gives a wider bone, and we can make it like an angle when you harvest it in the L shape. And the segmental perforator allows for opening osteotomies, and thick bone stock is for the osseointegrated implants. And the flap can be harvested without skin paddle. Many a times the skin paddle become very thick, and adjusting and mobility will be restricted. In such a cases, it can be harvested along with the skin paddle based on the groin flap, but you need another anastomosis for that. The next bony flap is a scapular flap, which the lateral and inferior part of a scapular border can be harvested as a bone flap. Usually it is harvested along with the other soft tissues like a skin paddle, and sometimes muscle can be harvested as a chimeric flap. It is mainly supplied by the subscapular circumflex scapula, which is basic. The subscapular artery arises from the axillary, which gives a circumflex scapular, which gives a horizontal and descending branch. On that basis, on that branches, we can harvest a skin paddle, and the main blood supply to the bone is from the branches from the lateral border, is mainly from the branches from the scapular artery, and for the inferior angle it is supplied by the thoracodorsal perforator from thoracodorsal artery. So, and we can harvest bone along with the skin paddle, either horizontal or vertical paddles, as a chimeric flap, and we can harvest up to 3 to 4 centimeter wide and 10 to 12 centimeter length of a skin, the bone along with this flap. The only disadvantage in head and neck reconstruction is we have to turn the patient, and it takes some extra time harvesting and anatomy. The commonest soft tissue flap is an anterior lateral thigh flap, and it is a fasciocutaneous or a musculocutaneous flap. The blood supply is descending branch, which is arise from lateral circumflex femoral artery. This lateral circumflex femoral artery is arising from profunda femoris, and this gives 3 branches. One is ascending, one is a transverse, and the descending branch. The ALT is based on the descending branch, which between the vastus lateralis and the rectus femoris, and this gives a multiple perforators, either as a septocutaneous and a musculocutaneous. Septocutaneous around 20%, and most of the times is musculocutaneous. And the pedicle length is up to 7 centimeter, maybe longer, depending on how the flap is designed and where the perforator enters. Yeah. This is a picture showing the septocutaneous and musculocutaneous branches. And usually this is used as a soft tissue reconstruction head and neck, and also for a pharynx. And also it is harvested as a whenever anterior lateral, the same the descending branch gives a medial branch. On this we can harvest an anterior medial thigh flap if we don't get any perforator on the lateral side, or we can harvest as a separate. This is how. Next commonest soft tissue flap is a radial forearm flap. This is harvested as a fasciocutaneous flap or osteocutaneous flap. The blood supply is from the radial artery, which traverses between the septum, between the FCR and brachioradialis. The radial artery gives a 9 to 17 septocutaneous branches in the distal half of the forearm. And the drainage is by 2 systems. One is superficial, the cephalic vein and a basilic vein, and a deep vena committant. These vena committants are most of the times very small, and hence cephalic vein is harvested along with the radial artery in most of the times, in all the times. And the skin paddle, we can harvest whole of the forearm from nearly 2/3 of the forearm. And it is used for the any soft, wherever we need a thin tissue, for example for a buccal mucosa, or for a lip, or for the tongue. This radial artery forearm flap is used, and also for the pharynx reconstructions. Another other soft tissue free flap which is used whenever to hide the donor side is a thin flap is required, is a lateral arm flap. It is most commonly harvested as a fasciocutaneous flap. Maybe it can be used as a osteocutaneous flap. And it is the blood supply is brachial artery gives a radial collateral, and which gives a posterior the branch of posterior radial collateral artery is the main pedicle for the lateral arm flap. And this traverses between the anterior and posterior condyles, mainly biceps and brachialis anteriorly, and triceps posteriorly. And pedicle, usually the pedicle length is very small in the lateral arm flap. Hence, if you take a skin paddle in the arm, if we want a longer pedicle, so we can extend the flap on the forearm so that we can get a bigger longer pedicle. And the other thing is when we dissect the pedicle in the proximally, we encounter a radial artery. So it's very important that we should not injure the radial artery when harvesting a lateral arm flap. Another soft tissue flap commonly used is a medial sural artery perforator free flap. It is a fasciocutaneous flap from the calf area. The medial sural artery is a branch from the popliteal artery, which passes through the medial gastrocnemius, and once comes down, it gives a branches to the skin perforators, and it gives a number of perforators about 9 to 18 centimeter below the popliteal crease. So and usually the pedicle length we get in this is around 7 to 9 centimeter, and it is a very thin pliable flap. Usually it is good for the buccal mucosa, tongue, and other wherever we need a thinner flap. And the only thing is, if you take a bigger, wider flap, we need a skin graft. For a small width, this is ideal for a thin, where we need a thin flap. The other commonly required flap for the head and neck reconstruction is a free jejunum flap. It is a small bowel flap with a route of mesentery, lymphatics, and mainly the blood supply is from the superior mesenteric artery and accompanying veins, and it is harvested. Can be dissected up to 15. The pedicle length we can get up to 15 centimeter, and the length is depends on the length of a defect of a pharynx, and we can harvest. And very important thing, the ischemia time is very short in the jejunum, so very quicker anastomosis is required, and usually it is used for the circumferential defect of a pharynx. Thank you.
Thank you very much, sir. This is for delegates. You can post your queries in the chat box so that the concerned faculty can reply in the chat box so that we can save the time. And now I request Dr. Shanta Kumar sir to introduce our next speaker, Dr. Prabha.
Dr. Prabha Madam is presently working as a director in the Plastic and Reconstructive Surgery Department at Sir H.N. Reliance Foundation Hospital, Mumbai. Madam, I think, doesn't need an introduction, but still a lot of postgraduates, young people have joined. So, and Madam has completed her MBBS and MS from University of Mumbai, and she got trained in microvascular surgery from Italy. After she was working as associate professor in the Department of Plastic Surgery at Grand Medical College and JJ Hospital, Mumbai. Then she moved out to Tata Memorial Hospital. There she was being head of the department for many years, and she was retired from Tata Memorial Hospital. Now during that time she has trained more than 150 reconstructive microsurgeons across India and neighboring countries, and she is the instrumental for the current reconstructive microsurgery in India. And Madam was the past president of Association of Plastic Surgeons of India, and the most memorable conference of OPSICON we can cherish forever. It was a Golden Jubilee conference in 2015, OPSICON, wonderful conference that was the Madam conducted, and she has performed a lot of more than 5,000 free flap reconstruction, and same thing she has bent down in her experience in a book titled called Mastering Cancer Reconstructive Surgery with the Free Flaps. So there are a lot of things about Madam, but this is a brief introduction. Madam, please take over and start now. Madam?
Good evening.
Yeah.
Thanks for a very kind introduction.
Yeah.
I think first two speakers have really said so many things which I thought I would be sharing, but that makes my job simpler. Okay. Onco reconstruction, I think it is nothing very different now. All of you have seen it. There are so many conferences and happening, but there are certain basic things that the cancer deals with. So treatment of cancer is not only surgery, it is surgery, radiation therapy or chemotherapy, or a combination of one or two of the modalities. So this surgery being the main line of treatment in most of the cases, these surgical excisions usually require wide local excision so that you have clear margins. So these surgeries result into letting small to large area, superficial or deep, only soft tissue, only bone or soft tissue and bone, lining bone and cover, or involvement of an adjacent structure like with mandible, maybe tongue is involved. So these, I mean, you don't see it routinely in our plastic surgery practice, but you get variety of defects that you need to cover. So what is the requirement? What is so different about oncosurgery? It demands primary wound healing because most of the time patient may require post-op radiotherapy or chemotherapy. So here, that's why there is no role of delays or tissue expansion. So the primary wound healing, so that the adjuvant can start in time. If the adjuvant does not get started in time, then the whole benefit of adjuvant goes. And then the whole surgery will be not successful in curing the disease. And with that, we need to preserve and restore the function. Because of the recent advances, more and more techniques are free flap armamentarium, then better radiation techniques, targeted therapies in chemotherapy, the longevity of the patient has increased. So hence the quality of life becomes an more our goal to provide it to the patient so that patient can go back to the society. So what are the principles of any reconstruction? That's our tone. Replace like with like whenever possible. That's the dictum of reconstructive surgery. So usually you were taught about the reconstruction ladder that you can allow it to heal by secondary intervention, or you have a primary closure, advancement flap, local flaps, right up to the microvascular free tissue transfer, and now in fact and transplant also. So depending on the situation, so many things we can, depending on the local tissue availability, what is the post-op scenario. So we may not follow the reconstruction ladder as such. You can jump on any ladder, 2-3 steps, and you can directly go take an elevator and go to the free tissue transfer. That depends on the defects that we get. So head and neck, I think, is the most action-packed region functionally and aesthetically for us. So what are the, you need to assess the defect. What should be the defect? That is whether the mucosa is resolved. What are the functions of that? Like mucosa is very stretchable, it secretes, it seals the mouth. Then whether subcutaneous tissue or muscle, then your cosmesis and animation, your movements get affected. Whether it is skin, then the cosmesis, because the moment the skin comes out on the skin and you use a flap from somewhere else, it will always look like a patch. Whenever bone is, whether bone is involved, then because that will require dentition, occlusion, it's eating, it's speaking, everything gets affected if the bone is not replaced. Tongue as taste or speech and swallowing and eating. And lip also for speech, sphincter, that is competence. And of course, it has a lot of importance for cosmesis. So all these things you need to assess. One may be joining with the other, that along with the lip, you may have a buccal mucosa, or along with the mandible, you may have a tongue defect. So while planning whether this surgery was a primary surgery or it is a recurrent disease. If there is a recurrence, that means the neck dissection has been done, the patient may have received radiation, and it is not a virgin field. So you will have a lot of scar there over there. What is the condition of local tissue? Will the local tissue, is it adequate to cover the defect? Does it need tissue from somewhere else? Whether it is specialized tissue is required from somewhere else? What functions are affected, whether it is oral competence, whether it is tongue movement, whether it is jaw, or whether you need to cover the brain in a skull base surgery. Whether patient has received radiation or not, that makes a lot of things little difficult. It's not impossible to go in and post-RT area. Whether post-op radiation is required. Then whenever radiation is required, usually you need to provide a good cover in that area. So you cannot leave it just for a grafting, and you can't use a random bone graft. Or are there any comorbidity? All these different points we need to consider, and then look for the donor areas. What are the donor areas that you can use? There are n number of flaps of our body. But like Dr. Prashant had said, there are few flaps that I myself used to say that you learn 3 flaps and then you will be able to manage any defect anywhere. So defects could be very small, like these lip defects, where you can do a local flap, or it can be lip sharing technique, or you need to borrow something from the nearby area, or you need to add tissue from somewhere else, or along with the bone, along with the whole lip, there is bone gone, or this is what I said, lip with buccal mucosa. I mean, there are a variety of defects they'll get. Whenever possible, lip sharing technique, if it is possible, that gives you the best functional as I mean cosmetically acceptable and functionally very competent oral commissure that you get. But for any lip sharing techniques, your buccal mucosa needs to be very pliable, then only these local flaps shift. When the lip primary closure may make it very tight, so then you can bring in nearby tissues. So that is the nasolabial region. This is one where the fibula has already been done, but what we had given and what post-RT you get back is a little different. The whole flap gets stuck. So this was a flap was raised. He wanted a lip, didn't want many major surgeries. So these are bilateral nasolabial flaps. That is how the oral competence. This is immediately on table and this is late post-op. So the local tissues do have a role, but when you require large amount of tissue, the local tissue may not be adequate. In that case, you bring in a tissue from far off, like FRAF, where you require thin pliable skin. But to give a good competence to this, you can do small adjustment of the local flap, do a small slender flap. So your oral commissure is very good. The moment you add flap to the lip, so that area may not be competent and he may drool in spite of doing a very good reconstruction. So these are small tricks that you do to give the best outcome for the flap reconstruction. But when these defects from the lip starts going laterally, or you require a marginal or require resection of the masseteric muscle and all that, the third dimension comes in view. So usually we'll think about the cover, lining and cover. So we don't think about the third dimension. In such a case, if we put a very thin flap, it won't look nice. So this also needs to take in consideration, and as per that, one needs to look for the flap donor areas. So usually these require flap like ALT flap. Here there was a big defect. This was part of the ALT flap. It was deepithelialized and that was packed in there, and this is his post-op appearance. Just imagine putting an radial artery forearm flap. So these are the like for like. If you don't replace, if the buccal mucosa is skin grafted, there is hardly any mouth opening. If though it is replaced by a flap, but the third dimension was not taken into consideration, so then you get a sunken appearance. Here the third dimension is taken into consideration. The bulk is there, but over a period of time it will go. So the aesthetically will look very nice. But the moment the skin paddle comes out, whatever you do, it is very noticeable. But sometimes it's not always possible to close that with rotation flap from the neck. Whenever bone is required, like replace like with like, it is very important for the mandible or the maxilla. So when no bony reconstruction done for the central defect, you get an antegum deformity. The patient cannot sit and eat, he needs to lie down and eat. So he becomes a social recluse. He doesn't share his life with anybody. That's not the life that you want to give it to anybody. Same in the deformity, if it is replaced with a bone flap, this is mandibulectomy, I mean segmental mandibulectomy done. That's the bone in position. I don't have to go in detail of osteotomy, how we do it and all that. Once the patient closes the mouth, you can hardly make out that something has been done because there is no lip split. So only the neck scar is there, that also becomes hardly visible. So for patient can go back to share his life with his friends and family members and go back to his original occupation. But when the defect is large and the outer skin paddle is there, many times depending on the leg size and patient's height, you can convert that fibular flap into a chimera. That one is a skin paddle, one other one is a bone with a skin paddle. So one goes for the lining inside and the other one comes out for the cover. So instead of requiring two donor areas, you have chimera flap from one donor area. So this is the best outcome that you can give it to that patient. But many times the defect is too large. The leg may not be that big. Then you do require to think about doing a double free flap or double flap. One can be free, one can be pedicle. But just look at the flap that we have done. This is an ALT outside and that's a fibula inside. But post RT, now see the amount of flap and see the amount of flap that is after radiation, what happens. But even if you are 10-15% more, it is unpredictable which patient will have that severe reaction and contract. Maxilla, I think it is still one of the most challenging defects to reconstruct. And it is aesthetically very disabling for the patient, affected patient, if proper reconstruction is not done. This is one such patient where the maxillectomy was just replaced with an ALT flap. This is how he is. But the same thing, now we are replacing with a bone, though it is a total upper alveolectomy with skin excision. This is how the flap has gone in. That's the skin paddle which has come out, and that's his late post-RT photograph. So this is what you are doing, and functional reconstruction for the patient to go back to the society. Now about tongue defects. We do use what percentage of tongue that requires reconstruction. See, many times you are doing flap to replace the tissues to have function, like mandible is replaced with fibular bone. So have your dental implant and patient can be chew and eat. But in tongue, when you are doing a flap for see anterior third to third glossectomy, hemiglossectomy, this can be rotated and closed primarily, but that reduces the effective length. But the flap that we do, that's 30% we can say almost can close primarily, because we do take tongue flap for certain closure defects of palate or the RMT lesion. But the flap that we do is a thin pliable flap like radial forearm flap, which per se does not function, but it allows the remaining normal tongue to function. That's the job the flap does. It doesn't allow the remaining normal tongue to tether down. That's why you need to do reconstruction of these defects. So this is what is hemiglossectomy done, and this is what we aim at. This is the sort of thing we should have. So this flap allows the remaining tongue to function. This per se is only skin and fat. So it doesn't function on its own. But whenever it is like total glossectomy, so there your flap is to occlude this. This is the mandibular border, and that's the soft palate. So the whole floor of mouth is connected to the neck. So you need to obstruct that. You need to close that, and you need to give a mount which can occlude against the tongue, not to have a crater here, so that it helps in speech and it helps in deglutition. So this is what is his on table. This is after a few days. This is after a few years. It almost gets necrolized. So each time a flap is planned with certain thing in mind, like Dr. Prashant had said, that you need to have the final result in mind and what minor procedures you'll have to do. So all our aim is striving towards adding life to those years, instead of adding only years to the life for the patient that we think of. And in head and neck region, secondary reconstructions are very tricky because of the post-radiation. So that is one region where primary reconstruction is desirable and must be done to give the best functional outcome to the patient, functionally also and aesthetically also. And you have n number of flaps, like I have said, but you need to choose few. And if you master these three flaps like fibula, ALT, and radial, you can cover almost head to toe almost each and every defect, whether it is 5 by 5 centimeter or whether it is 30 by 25 centimeters. So these three flap you master, you can cater to any flap. Over and above, you are all surgeons, so you can always do a different flap, like DI flap for the breast, or any other flap you want to do when all these flaps are being used. So there is, once you are a surgeon, you can choose a flap and do it. It's not that you need to do only radial for these defects, or only if your ALT may be as thin as radial. So instead of taking radial, you take an ALT flap. So you need to look at the donor areas. What is the requirement of the region? and then only go for the flap and have the tentative plan in mind. But onco is one setup where suddenly the surgeon will say, see, I had to remove more because the margin was positive. So you need to adjust and change your plan on table. So that's what our planning in reverse and everything when we do it for trauma, it doesn't work like that in onco. So onco, you may have to be prepared for a sudden change in plan or sudden some defect is given and how to manage the local tissue, how to adjust the flap. Even harvesting a flap and putting a flap, it is, yes, it is challenging. Micro is one important, anastomosis is one important aspect of that. But how you adjust the flap, how you turn the flap, how you use the local tissues, some local adjustment to give the best outcome. These all things you need to do, and that usually are per primum, because post-RT usually will not like to touch the patient for a few months to a year till the ET-RT effect settles down. So I think there is no role of delays, there is no role of tissue expansion. And primary wound healing is the main, just to cure patient from the disease so that the adjuvant starts in time, with keeping function and aesthetics in the mind all the time. I think there are too many things to share, I think, but for this time, for the timing, I think this is just a glimpse of what onco reconstruction involves. Thank you.
Thank you, ma'am.
Thank you, madam. After that insightful talk from Dr. Prabhayadar, madam, we will now move to our next topic, an important topic that is now slowly gaining importance in our country, that is breast reconstruction. Our next speaker, Dr. Ashok BC, again doesn't require any introduction for most of us. He's a senior consultant in plastic surgery at Manipal Hospital, Bangalore, and he's previously served as the HOD in the same department and is also co-director of the breast surgery fellowship at Manipal University. He has been working in this field for more than 2 decades now, and he has a special interest in breast and lymphatic surgery. I now invite Dr. Ashok sir to talk on autologous breast reconstruction. Ashok sir?
Yeah, I am. Yeah, I'm just.
Yes.
Trying to share my screen. Share. Okay. Good evening, everybody. Can you see my screen?
Yes, sir.
Yeah. Thank you very much for the introduction. And though it is a head and neck reconstruction course that has been organized, Prashant has asked me to speak about autologous reconstruction of breast, which is also an important aspect of reconstruction for young plastic surgeons who are trying to master the art of reconstruction. So today I'll talk only about autologous reconstruction. And we all know that breast reconstruction is non-essential for sustenance of life, but it's completely proved that quality of life improves after doing this kind of reconstruction, and the incidence of lymphedema decreases. And over a period of time, because there are so many, the incidence of breast cancer is rising so much, the requirement or the need for reconstruction has also increased significantly, and people are aware of it. And now added to that, we have now risk reducing surgeries where people undergo double mastectomy when there is BRCA mutation. So that has also increased the demand for breast reconstruction. And being plastic surgeons, we will always tend to be slightly more inclined towards doing autologous. We all know we can do primary or secondary reconstruction of these breasts, because unlike head and neck, we don't really need to do primary if patient doesn't want or patient is not fit for surgery. And we need to discuss with the patient a long, hard discussion about what are the options available and what is the best outcome in terms of what is the tissue available for us and what is the patient's demand themselves, what they want at the end of reconstruction. So we can divide autologous reconstruction into two main categories: pedicle flaps and free tissue transfer. And pedicle, there are only two ways to do it. Either we do a pedicle LD or a pedicle tram flap. Free tissue transfer, there are many flaps available from all over the body, but a dia flap is the gold standard. Against all other flaps are measured, and also if other flaps are considered only if dia is not possible. Okay. So we all know these advantages and disadvantages. We'll discuss this in detail when we do this course. But always autologous reconstruction scores over implant-based reconstruction or an hybrid reconstruction in terms of how the breast behaves, how it feels, infection, the resistance to infection and radiation. All these are advantages. The minor disadvantage is the time what we take, and if there are complications, it will potentially delay the treatment. So if we can offer them a good, quick autologous reconstruction, nothing like that. So pedicle tram, this was actually more anecdotal now. Not many people do unless they don't have a facility for microvascular. Superior epigastric vessels is what is used, but the whole of the rectus muscle is used as a pedicle, and the harvest of the flap is from the lower abdomen, exactly like a tram, a free tram or a dia flap. But the problem is that zone 3 and zone 4 are very unreliable, basically because it relies on the anastomosis between the superior and inferior epigastric vessels somewhere here. So if this anastomosis is robust, then this flap does well. Otherwise, you will have some necrosis of the skin pattern. And also, it is very, very morbid to the abdomen itself, harvesting the whole, not only in terms of having hernia or bulge, but even functionally, patient trying to get up from bed and all that will be a major issue after harvesting rectus muscle. So these are many types of anastomosis which we can find, and some are good and some are not good, but it's very, very difficult to pre-operatively determine this. So that's why we end up having unpredictable results. And patients will need an abdominal repair with a mesh, otherwise they will have hernia bulge. And as I said, the skin paddles are very, very unreliable, and sometimes even with doing a good job, half of, just across the midline, everything goes off. And this kind of small necrosis are possible if you are doing a pedicle tram. And because the pedicle is going across here, the lie and the maneuverability of this flap is limited. So in certain flaps, in certain breasts, it's very difficult to match the opposite side. So these are some of the disadvantages of doing it. Latissimus dorsi is a good flap to do if the volume of the breast is small and the patient is having good amount of lipomatous tissue in the back. The skin paddle itself will be limited. Whatever we can pinch and close primarily from the back, we can use it. If you want to do a bigger flap, a bigger breast, then you need to include implants under this thing. But primarily, you can still do latissimus dorsi flap. And other disadvantages, we can start this harvesting of this flap only at the end of doing a mastectomy, because we need to change the position of the patient. So that's the disadvantage. So what we can do is actually we can take a skin paddle in any direction, vertical, oblique, or transverse. We pinch and see what is possible. Otherwise, it's exactly like how we do a latissimus flap. We all know how to do a latissimus dorsi flap. But when we are harvesting the muscle, we take a lot of fat as well. So you recruit more amount of fat so that it gives bulk to the flap, and then you tunnel it and bring it into the cavity and close it. This is the post-op picture of a patient who has undergone complete breast reconstruction using only LD flap, and that's a donor side defect. You can see all this because of the harvest of the flap. There is a little bit of hollowness, but that is acceptable, and the scar is well hidden inside the bra line. So you can only do with small breasts like this. We cannot do a large breast reconstruction with an LD. And even then, there might be some amount of asymmetry which we need to correct secondary. So the only contraindication for doing this is when they are doing axillary clearance, if the pedicle is damaged or they have a previous history of thoracotomies, we should not be doing these flaps. Among the free flaps, tram and diap are more common. CI sometimes can be done if the vessels are big. All other flaps, tug, S-gap, and I-gap, and ANT, RPF, these are all considered as secondary flaps only if a diap is not available. There are many ways to describe how the vascularity of this diap flap goes, zone 1 to zone 2 and zone 3 and zone 4. And this is Holmes is what we normally follow. This is very reliable on one pedicle, and a little bit beyond the midline is also okay. But if you want to harvest zone 3 and zone 4, you might have to take a pedicle from the other side and anastomose it to another recipient, or you can do an intraflap anastomosis. So you need to examine the patient and see what is the deficiency you're going to see, whether there is skin deficiency, what is the quality of the skin, what is the size of the breast on the other side, whether they will agree for symmetrization, whether there is lymphedema like this. So all this will help to determine, and also we need to examine the, abdomen as well, whether enough skin is available for us to reconstruct the size of the breast, and the perforator, whichever is suitable, whether it is on the right side or the left side. Ideally speaking, ipsilateral pedicle is much better because the superficial subcomplex iliac vein, SIEV vein, what we call, will automatically line towards the axilla. Sometimes we need a second vein to drain these flaps. If you take this same side, then the orientation of the flap is much better. We measure the skin, as Dr. Prabhaya, the madam, was telling. Planning in reverse, we can do it here because they want to remove skin. We know how much skin to leave, how much fat we require, and what has to be discarded. We can plan. We can reconfirm the perforator by using a handheld Doppler, but CT in diap flaps is most important thing to do. This tells us where what is the kind of branching pattern we have on the diap vessels and how many perforators and where they are situated. So it saves a lot of time for us, and we don't need to dilly-dally chasing around all the perforators what we find while harvesting the flap. So you can see here how the perforator is going, and we can decide which one to take. And the difference between a tram and diap, tram we take a small piece of muscle as well, along with the deep infraepigastric vessel. Here we dissect through the muscle and take only the perforators. Whether it is medial or lateral, doesn't matter. The tram has a piece of muscle, as I said, so it naturally starts mimicking the shape of the breast. In diap, there is only a vessel which is connected, and it is a flat flap. So we need to mold this into the shape of the breast. And the vessel lies here under the muscle here. Here we dissect through it, preserving all these intricate nerves which come from lateral to medial side, so that the function of the muscle is preserved. And this is the defect. After that, we need to use a mesh in tram. Here we can just close it primarily because we have not damaged the muscle as well. So anastomosis, you can use many. There are lots of vessels available in the axilla, like thoracodorsal or serratus branch. We have internal memory system in the medial side. Anyone we can use. We prefer to use internal memory most of the time. And even retrograde IMA and the lateral thoracic vein and cephalic vein can be used to augment the venous drainage. So additional anastomosis is sometimes required when you use zone 3 and zone 4, and we harvest both sides the pedicle, and then we connect them first before connecting it into the, like this, we connect it and they can connect. So we get large amount of tissue which you can play with to reconstruct and match the. So this is what happens in diaphragm. Most of the time it's okay, but in some cases, even a recipient, I mean, in the native site, once you harvest the flap, you can see the SIV veins are engorged and the flap itself is looking a little congested. It is only draining now through the pedicle. So in such cases, you need additional venous anastomosis. Here we have flipped a cephalic vein and connected it, and the redness and the condition goes away. So whenever you do diap, you should be always ready to look at another additional venous outcome. So these are some of the results. Whether you do tram or diap, it doesn't matter. You need to get primary healing first of all, and you need to plan in such a way you put in adequate volume and you make it into a shape where it matches the opposite side. In Indian scenario, there is only one chance you get to do this. People won't come back and get revisions done time and again. In my practice itself, about less than 1% of them come even for nipple areolar reconstruction. So it's very, very rare they will come and ask for. So first time is the best time for you to get the best result. So some more results when they do mastectomy, you can match the opposite breast. Here's another case, total mastectomy, tram and diap. This is nipple, I mean, skin sparing mastectomy, only nipple areola is removed. You de-epithelize rest of the flap and put it inside, and skin paddle can be left like that small to mimic the NAC. If they want, we can reconstruct NAC as well later on. When there is asymmetry, we can take it into to our advantage and match the opposite breast when we do this. And this is a very rare case where we could do nipple areolar reconstruction with tattooing. This is nipple sparing mastectomy, which is coming now in a big way, especially in risk reducing surgeries where they keep the nipple as well. And all you need to do is fat fill with diap flap. Complications you can have at the donor site, like a bulge or a hernia, and but if you do good job, whether it is tram or diap, you will not see any difference in terms of how the abdomen should look. And this is sometimes you see this kind of congestion and diap flap in the first, second day if the venous drainage is not good, but it disappears by third, fourth day. But it is very, very difficult early enough. So always, if you're doing diap, always do a second vein initially, at least till you learn how to negotiate these problems. So tram is easy to do, and more than 1,000 grams of breast can be reconstructed. But diap is the in thing. It is the Ferrari of reconstruction. Everybody should learn this technique if you are going to do any kind of breast reconstruction. This was a very good article telling the complications and advantages of tram versus diap. It says tram is good for breast, but diap is good for abdomen as well. So that's so the contraindications are high BMI smokers and contraindications to long anesthesia and previous abdominal surgeries or liposuctions. You need to be careful when you're doing these kind of surgeries. TUG I would skip in this because I don't do TUG, but this how TUG can be used if an abdomen is not available. ALT very, very rarely because it leaves an ugly scar on the thigh because it cannot be closed primarily. But if there is no other alternative, you can still consider this as well. Nipple areolar reconstruction, tattooing, very rare, but some people will come. You need to learn this technique. It's simple and you can do that. So when we come to the meat, we will discuss these techniques of how to harvest and what are the problems and practical aspects of this. and hope to see you there soon. Thank you very much for patient hearing.
Thank you, Ashok sir, for that in-depth talk on breast reconstruction. I would now like to invite our next speaker, Dr. Madhusudan sir, who is the lead consultant at Aster CMI Hospital, Bangalore. He's an alumnus of DMC and the prestigious PGI Hospital in Chandigarh. Coming from an ENT background, he has a passion for rhinoplasty and all other facial plastic surgeries, and he strongly believes that believes in keeping an enthusiasm to always deliver the best possible to the patient. So I now invite Dr. Madhusudan sir to speak on a very important topic, that is preventing complications in plastic surgery.
Unmute.
Hello, sir.
I'm
Yes.
audible now?
Yes, sir, you're audible and your presentation also is visible.
Thank you.
You can maximize the screen, sir.
Maximized?
You can start the slideshow. I mean.
Yeah. Is it maximized?
The slideshow is not started, sir, actually.
It is done. It's maximized in my system.
Can you click on resume slideshow there, sir, on your screen?
One sec, I will just share the screen again, please. Sharing. Can you see the PowerPoint now? Resume the slideshow. Okay, okay.
Yeah.
Is that fine now?
Actually, it's still in the window, sir. The slideshow is not started. We can see your screen, but the slideshow is not starting. Is there anyone from the technical team?
Yeah, hi, doctor.
For me, it is slideshow.
Madhu, you completely come out of it and reshare again.
I did again. I stopped sharing now.
Close it and open again.
Yeah, I opened it, sharing the screen now. Is that my share screen is seen now?
So we are not able to see your screen, sir.
Now?
No, not really. I think what you can do is you can try to reduce the slides.
Still no?
Yeah, now it is visible, sir.
Yes.
It had come but went away again, sir.
I think screen sharing option is gone for me.
Can you try again, sir?
Yeah, I will do now. Is that seen now?
Yes.
Slideshow I'm opening. Is that seen now?
I think there is some technical problem. Why don't you get those slides which are shown by the side of you, sir?
See, okay. I'm sorry. Is this not for me? Slide screen is open now completely.
I think, doctor, if that is not working, we can present with this one,
Yes.
or you can click on the slideshow in the menu bar. I think that should work. You can just try that once, and if that's not working, we can present in this part only.
Just below that, you have the option to enlarge the slide. Just below the on the side to right side of that, you have an option to enlarge the dimensions of the screen probably.
Okay. I'm enlarging to 100%. Is this now?
No, it's not working.
Maybe Prashant, don't waste time. Meanwhile, I'll check you can do your presentation. Maybe I can do it late if the time is going by.
No, I think we'll go ahead in the same format, sir.
Okay.
Issues afterwards also.
I don't know.
We can get back to the previous 69%. Because the slide is
become 100% now.
But the entire slide is not seen, only the upper
We will.
No.
I'm zooming. I don't know.
You can click on the percentage and select again the 60% one. Just click on 208%. Yeah, you can come here. Yeah, this one we can continue.
71% now.
Yes.
Is this slide share seen now?
No, I think you can continue with the same, sir.
Is this okay?
Yes.
Okay. Thank you. Sorry for that technical hitch. Thanks for inviting me to present the very tricky part in microsurgery, preventing microsurgical complications. A partial failure of free flap is still one can, like this is an LD done for a dorsum of foot defect, and you have a little bit of distal muscle necrosis and partial failure. You go ahead and then debride a little bit and close it. You still be happy because you are not lost complete flap. But when it becomes a complete failure, like you lost a whole of the LD for a dorsum of foot defect, and you feel like it's unforgivable for a microsurgeon and unforgettable also. So flap failures, a failure of microsurgery is an ultimate threat to a microsurgeon, and it makes.
Sorry to interrupt, sir. Are you moving your slides?
Yeah.
I think you can come out of the full screen and you can present it in the tab.
Like this? This way?
Yeah, you can come out of the full screen. Like the regular presentation that we have when we are making presentation, that view may be better.
No, this is, I have not come out of the full screen now, but it is not being shared now.
Yes.
Is this shared now?
We are able to
just change your slide. Let us see. Go to second slide.
Okay. One second.
It's not changing.
Yeah.
This is seen now. Yeah, go ahead.
Go ahead.
Yes.
Yeah. Can I go ahead, please?
Yes.
Yeah. The partial failure, sometimes we can go through it and then finish our what we have to do. But when it comes to a complete failure, it becomes very unforgettable. And failure makes a microsurgeon like hesitate to go for one more microsurgery. It becomes a very disheartening experience for a microsurgeon to have a failure. So because it's irreversible, any free flap is all or none phenomena. You have a complete loss of the flap and it needs a reconstruction. Most likely it's where you have chosen a free flap for a defect or for any cover, and you need to do a second free flap only. Most of the time you need to do a second free flap for a optimal reconstruction. That becomes a challenge. So how to, because once you have a failure, it's very difficult to go back and do things. We need to know how to prevent a microsurgical complication. That all in the planning, anticipation of the problems that can happen in microsurgery. You should be open-minded to listen to your juniors, seniors, and not get into a fixed mind and getting ego in your when you do a free flap. And never say die. Don't leave it. Try to the best so that your flap is succeed. And end of the day, if you have a failure, then you should know how to cope up with the failures. The factors which influence the microsurgical failure can be classified as preoperative, intraoperative, and postoperative. Preoperative factors: patient selection of the flap, and the supporting what you have for a free flap. But at the same time, the preoperative factors of a surgeon, that's the patient factors, flap factors, and the situation factors. The main important is the surgeon factor, the ego of the surgeon, what is the emotion you are attaching to a free flap, attaching to the patient, and the final outcome. And it's your confidence of doing a free flap or overconfidence of choosing a flap. All this end up in your results. So you should be careful in these factors preoperatively. Patient selection. Age is not an absolute criteria, because we have free flap can be done in as early as 1 year old and even at the 8th or 9th decade. Age is not an absolute criteria, but still elderly and a young age patient have a risk of flap failures. You should know the factors involved in that age-related unfavorability. An understandable patient is very, very helpful in a free flap, because you need to have him taken as a part of the team and then go through that, explain the person, the procedure, the how the patient has to cooperate and what we are doing and what is the time we involved in the surgical encounter, post-operative period of his coping up, and as well as the chances of failure, what we should do the secondary flap. Everything has to make sure that the patient understands. If he's an understandable patient, well and good. Or sometimes to the effect of patient's understanding, we should at least transfer the knowledge of what we are going to do. That makes us easy. The severe cardiovascular disease are really one of the bad things to go do a free flap. If there is a positional issues, we should know preoperatively what the position of the limb, especially in the lower limb, can happen, what flap you are going to do, the pedicle, where the pedicle comes, where the flap comes. We should be knowing it preoperatively and decide accordingly. See the local vascularity, see the either the arterial Doppler, see the pulses, whether a one vessel limb and atherosclerosis, anything, the elderly, diabetic foot. All those things you should know the local vascularity before contemplating a free flap. This unfavorable situations like acute infection in an area, I'm telling about an acute like a trauma-induced free flaps, where if there's an acute infection, if the local tissue edema, if there's an associated head injury, where you contemplate a free flap from other areas where the patient may not cooperate and you may not able to keep the position of the patient. So these are the unfavorable conditions where you should be really think before you plan a free flap. And if there's a serious previous flap failures in a specific patient, you go back and do a second free flap, or you go and do a salvage free flap, or the patient comes with a previous flap failure, you should be very careful. What are the reasons a previous microsurgeon has failed this patient? We should be careful before contemplating the second free flap. Flap selection, we should know the unfavorability, where you are, how the muscle is unfavorable in a specific situation, where the skin becomes unfavorable in specific situations, where you plan a skin flap versus a myocutaneous flap, where you plan a composite flap, and where you plan a chimeric flap. We should be proper flap selection, matching the tissue to the tissue. That also very important in final outcome of the flap. Muzzle flap, the unfavorability of muzzle flaps when it comes to LD flap, when you try to do a big LD flap at a smaller defects, there is a big gravity dependent recipient side where you put a flap where the gravity dependent part can cause the congestion and you lose the flap, and where you have a subdivision priority where the important defect to be covered is a distal end, you put a flap, the distal end is covering the important part of the need to cover, and ended up in the lose the distal part of the flap. No, that is one of the unfavorability of the latissimus dorsi flap. When it comes to gracilis, you compromise a defect size, try to do a gracilis for a bigger defect. And if there is a projecting surfaces like exposed phalanges, exposed bone, exposed pointing bone surfaces, and because in gracilis the pedicle is very short, if you end up anastomosing at the zone of injury, then you should know that gracilis is not the flap, in that even though the defect is small, you should prefer other flap. And sometimes dissecting gracilis alone in some very muscular patients, we may not be able to dissect the pedicle properly because of the tight muscle in between, and without a proper assistant, you might injure the pedicle during dissection and you may end up taking a shorter pedicle. In vastus lateralis, if you want to take this muscle, then it's very unreliable, and sometimes you get into congestion. Part of the muscle can die in between, the muscle part can become ischemic, and you might not get a very good result. When it comes to skin flaps unfavorability, you should know all these: radial artery, anterolateral groin, parascapula, lateral arm, medial surolateral flap, DF flap. You should know the where you have to plan, where you have to fix this, whether the vascular pedicle issue, where you need a robust pedicle, where you need the length of the pedicle, where you have a perforator issues, and consistency in the variability of the vascular pedicle and the venous drainage. That has to take into consideration when you're planning which skin flap to what defect you are planning. And size of the skin paddle, where we need a bigger paddle, definitely ALT is the better option. Maybe groin also a better option than a radial artery, because there is a lot of a donor set deformity can happen in RAF. So similarly, and also there may be issue with the angiosome, and you might end up the edge of the flap, and so we need to know the flap has to be planned according to the amount of the skin needed, and also the familiarity of the flap to the operating surgeon. And so more familiar the flap, you know what is the logistics, and you know it better, and the results are always better. Myocutaneous flap, the unfavorability of myocutaneous flap is where you take a part of the muscle and part of the skin, the orientation of the muscle as well as the skin into the defect is we need to know which part of the thing has to come there, and how the pedicle is going to the donor the we need to be careful. And sometimes when you do, especially in the ALT, sometimes it can become territorial, and you have an arterial, and it's better to do more veins. You have a lot of venous anomalies, and you have a lot of recipient veins. End up doing 2-3 veins is always better. You should know the venous anatomy when it comes to adding a muscle in the skin. And other issues, supporting issues when you're doing a free version, that also definitely use the equipment for the osteotomy. We might induce the pedicle. If you are not using a proper equipment, you may end up in losing the flap. And also you need to have a good team assistance. That's very important for a successful microsurgery. We all know that, because it is one of the important factors when you are doing a free flap. You should know how the assistance is very paramount importance for a successful outcome. Coming to the intraoperative factors, it can be technical factors, it can be non-technical factors. So important where we can do something is the technical factors. It can be divided as pre-anastomotic factors, anastomotic factors, and gestra anastomotic factors. In the pre-anastomotic, we have and in the recipient vessel dissection. Coming to the flap dissection in the RAF, one of the problems in RAF, we know that is cephalic vein or vena commitants. Whenever the time permits, we should try to do both vena commitant as well as cephalic vein. You should know before detaching the pedicle how the flow is going, whether the deep system, superficial system. Most of the time, we can a small is good enough. Yeah, sorry. Internet has a issue.
Yes. I think you
are
are
audible.
There's a lot of interruption in your presentation.
Am I audible now?
Yes, sir.
I think there's a network issue, I guess, sir.
Am I audible?
I think there's a network issue. A lot of what you're saying is not, you're not having a clean stream of voice.
I don't know, it was all fine. I don't know.
Madhusudan, sir?
Is it audible now?
No, you're not having a clean stream of voice.
I think internet is not very stable.
Oh. voice is not audible.
Hello.
Hello.
Sir, you can start, sir. Let's see how it.
Yeah, can I speak? Are you hearing
Yes,
my voice?
we can hear you now, sir.
Okay. Can I go ahead?
Yes, sir.
Okay. So in the radial artery, most important, whether we should know whether which vein we are to anastomose, better to use both veins. My experience of not using the fat along the cephalic vein, sometimes when you put a oral cavity, the fat might cause a twisting of the cephalic vein. You should be careful. So if you dissect it completely, skeletonize it, it's easy for you to untwist it. And because we always the flap under tourniquet, sometimes if you don't cauterize proper, end up in hepatoma. So you should be having a good proper hemostasis after the release of tourniquet before transferring the flap. These are the only factors in radial artery. Otherwise, it's one of the simplest flap. In the fibula, if there is a chance to do a pre-op angio, it's very good to know the vascular anatomy, the vascular anatomy of the limbs, and is there any anomaly of the peroneal artery. Short versus a long fibula segment is very important because sometimes it's easy to get a long segment and easy for a dissection. If you end up in taking a short fibula because your defect is short and you have a serious issue in dissecting the pedicle. So we should know that we should always harvest a long fibula even though you have a shorter defect. Perforators are easily seen in a posterior incision, and sometimes posterior to anterior favorability is better when you really want to know the vascular anatomy and go it. Dissection anterior to posterior, sometimes we are very comfortable anterior to posterior. Some people are comfortable posterior to anterior. Depending on your familiarity, you can go ahead and do the flap, but always choose your best familiar technique. Proximal osteotomy, when you do it, you will be very careful because you might endure a big vein which are deeper to the fibula and may end up in difficult handling the vessels, as well as you have tears, punctures. And also when you dissect the pedicle all along, we should be very careful where the time spending during the pedicle dissection is very important, and ligating all the vessels and clamping them so that and the vein will be very thin. If you tear a part of the vein, it will be very difficult and it becomes a troublesome even before the transfer. Instrumentation related injuries, also be very careful so that you use a proper instrumentation, have a good retractor so that you avoid injury to the pedicle at the same time. If you have an issue with the artery, then you have a primary flap failures, because this is one thing which I have seen in fibula, because most of the time if you have a problem because of the spasm or because of osteotomy, too much of osteotomy related injury, or the assistant is not giving a good irrigation into osteotomy, heat related injury, or maybe a vessel getting injured during your osteotomy are very important. We should be careful. And sometimes you have multiple punctures and tears in the venous all along, and so you end up in flap failure. So we should be very careful handling the pedicle when you do osteotomies. Make sure that the pedicle is taken care when you do the osteotomy. In ALT, it's the perforator, nothing else other than that. Whatever you do Doppler and come out and see, there may not be a perforator going to the skin, whether it is musculocutaneous, septocutaneous, and you have to refashion the flap according to the perforator you have seen. Sometimes you see a perforator, sometimes may not be representative. Perforator may have a good artery and we may not have a good venous drainage. The venous drainage may be going through the other pedicle or maybe through the muscle. You should be open-minded to make sure that you involve or go above to the facial at pedicle. You should make sure that refashioning and ready for always a bouncer when you do a ALT flap. When you get a good subcutaneous perforator, ALT is one of the simplest. Otherwise, one of the very tricky flaps. So sometimes you end up in no perforators, you might have to defer doing this flap. So and in most of the elderly patients, even the perforators are atherosclerotic. The vessel may be very highly atherosclerotic, and especially we are doing this as a flap to the other donor side, which is in the lower limb. Be careful about the atherosclerosis. If there is a severe atherosclerosis, sometimes this is one of the detrimental for ALT flap. the arterial supply may not be very good to the skin. It may be good for the muscle. So you may end up in doing, in such cases, you change that into lateral is muzzle flap and try to cover the defect. This muzzle is more reliable if you're planning covering of a defect rather than a skin to skin replacement. LD flap is one of the most commonly used flap for bigger defects. The pedicle dissection is the one which is very tricky sometimes. If you try to go hurry during the pedicle dissection and maybe you can injure a cartilage injury to the pedicle, you should be very careful and go with a very maybe a magnification, good retraction near the axilla, make sure that you get a longer length of the pedicle. Otherwise, the flap dissection is much more easier than any other thing. And when you're ligating the serratus branch, you should be careful that you're not ligature is not crossing that angle and clamping the vein or artery to the muscle. That is the one thing we should be careful. And you should also know the distal end vascularity, not to try to involve a working part of the flap in the distal end. Make sure that your osmosis is proper end and also the muscle is nicely covering the needed area. And choosing the skin paddle, always better along the anterior border, maybe along the upper end of the muscle rather than going to the lower end. Gracilis, when you're planning, sometimes the incision you should be careful about. You may end up searching the muscle going more anteriorly. That's the one thing you keep on searching. You may end up in cutting the saphenous vein. So you be careful that you should do a good preoperative marking and get into the gracilis well, because especially it's common in very fatty patients. It's very difficult to feel the muscle. And other thing is finding the proper pedicle. You should always find the nerve so that your pedicle is right thing, and not unless by chance inadvertently you're going to cut the pedicle, you're gone before you dissect the pedicle under the adductor longus. And as I said before, pedicle damage under the adductor longus, should be careful. Make sure that you are ligating all the branches to the adductor longus, which is going on the roof of this pedicle, and go dissect. Believe in the length of the pedicle. It will definitely get a very good length, because this is very important factor in your flap salvage. Because you get a good length of the pedicle, you can do a good anastomosis beyond the zone of injury, or you can get into the reach of recipient vessels. DA flap, I don't want to go in detail because Dr. Ashok has dealt in detail. Thing is, seeing the zones, amount of skin you have to use, and volume replacement. Sometimes a huge amount of volume replacement, thinking that we need to put a lot of fat there, you end up in compression of the pedicle, especially you are trying to do it to the thoracodorsal vessels. Be careful, try to deeptilize how much skin is required, how much fat is required. Put a smaller flap rather than a big flap when you are starting with, so that you not end up in a complication. Groin flap or a skip flap. This is one of the important flaps I want to tell you, because believe in the small vessels. Even though it's a little difficult to learn, but if you learn doing a free groin flap, this is one of the very nice flap to do. Proximal dissection needs a little patience, and always the artery and vein will not be together, because the artery will go to the femoral artery and vein will be going more medial to the femoral vein. The distance may be around 3 to 4 centimeters. You should be careful in dissecting proximally. That's the only thing here. And you should know the vessel size, because any vessel before cauterizing, you should make sure that it is not the pedicle. Before, in the initial start of dissection and initial flap RVS, you should know that which vessel is the one which is supplying. You should know the anatomy well and go about it. And keep as many veins as possible, so that you will have a venous anastomosis better. Reach as proximal to the positive. We should always remember Dr. Ashok Kaul. He is one of the person who believed in small vessels and showed that freestyle free flaps. And even though groin flap has a small pedicle, small vessel diameter, it is one of the reliable vascular pedicle. Recipient vessel dissection. In the arterial vessel dissection, don't underestimate the zone of injury. Extent of dissection, don't keep on dissecting too much. Then it becomes a too wobbly pedicle and very difficult to manage. Adventitial dissection ought to be just enough for your convenience. Check for a pulsatile flow. It's very important. Sometimes there will be clamping before, and you might just end up anastomosing without knowing a pulsatile flow. And if there may be a clot, and you may end up in problems during the anastomosis. Make sure that there's a pulsatile flow in the artery. See whether the single artery of the limb to plan end to side or end to end anastomosis, and also be careful about atherosclerotic vessels. Managing atherosclerotic anastomosis is one of the important factor, and sometimes it's inevitable when you landed up in a vessel like the recipient artery, donor's artery, with a huge amount of atherosclerotic plaques, and anastomosis becomes very tricky. In the venous part of the recipient vessel dissection, you should make sure that try to take deep vessels as far as possible. Avoid cutaneous vessels because the compressions are possible. Caliber, you should check. The patents you have to check. There may be venous thrombosis. There may be some infection, vasculitis, thrombophlebitis. You should be careful of using the veins. Pressure of the veins is very important. When you are doing a smaller flap with a lesser pressure, going to a bigger pressure vein. So you should reduce it by ligating the tributaries. Always try to find a second vein. It becomes very handy at times. And orientation of the pedicle with respect to the artery, vein with respect to the artery is very important. Try to make sure that there is no lot of complications or directions, different directions when you do the anastomosis. Intraoperative anastomotic problems, what matters is the bad clamps. Please always use a good clamps. Clamp related injury are very difficult to manage. Time spent on the clamps. Try to make sure that your clamping time is less. The vessel damage will be less. Memory of the lie of the vessels after the anastomosis, how the vessels lie, whether there's a king, where there is a tension along the suture line should be very important when you're thinking of the anastomosis. Magnification is paramount importance because that is going to give you the good view of what you've done. As far as possible, keep the artery and venous vicinity because arterial pulsation helps in venous drainage also. It is going to give a pulsatile pressure on the vein that helps in because that's how the vena committant drain partly. So keep vein along the artery is always better. Never artery going to compress on the vein unless we have some serious issues over there. Try to do more veins is always better, and usage of a proper needle is important. But what not matters is that how much adventitious dissection you are going to do. That should not be too much of adventitious dissection and trying to spend a lot of time under the clamp dissecting the adventitia is not good. And background, it's always convenient. Sometimes you may not need background to do anastomosis. Always using 10-0 may not be a strict formula. You can always go to 9-0 or 8-0 depending on the size of the vessel. Number of sutures. Trying to do too many sutures is not the key. You should do a proper approximation of the both vessels. It can be even 3 on each side also. If there is a good approximation with a good double knot in the first place, even the minimum number of sutures can do work. Leak, sometimes leak, unless it is a big pulsatile leak doesn't matter. You should do a good little pressure, give a gauze piece and leave it for about 5 minutes, it will help. The sequence, whether you do artery first, vein first, doesn't matter. Time of the clamp release, whether you release the clamp after both arterial venous anastomosis, do arterial anastomosis, release the clamp and do venous later, doesn't matter because it depends on the convenience of the operating surgeon. It is not the one which is going to give you the success or the failure. And as I said, artery compressing the vein, you should not be too much thinking about this when you're doing the anastomosis. Intraoperative other factors is that if there is arterial failure during intraoperative stage, it is very detrimental. That is very, very dangerous. We should always go and check. Leave your ego, go and redo. That's what. Go to the basics, see where the artery is having an issue, do the artery. That's very important. Do it as early as possible. Heparinize. Try to do papillary if there is arterial spasm. And ready to vein graft. If there is a lot of tension along the arterial pedicle, don't hesitate to go for vein grafts. If the short vein graft, even 2 centimeters or 3 centimeters is very, very important. Take a vein graft, go ahead and do anastomosis. That's going to help. If there is a venous failures, then maybe technical and both technical and non-technical. Length is a very important thing. They should not be tight, not tight or not loose. And you should know the twist of the vein. It should be very deceptive sometimes. most of the time, that's why I do artery and make sure the vein flows, and then make sure that it is not twisted and do the vein. So always go and relook where all the problems are. And venous failures, venous problems are always easy to handle because you have an artery already perfusing your flap. You should not be very touched out because flap is surviving. You might have some blood loss. Go ahead and redo it so that the flap survives. Always try to do a second vein. Some other intraoperative just anastomotic problems that can cause issues in your vascular compromise is one, adjustment of the pedicle. Sometimes the artery is very short, the vein is long, and you end up in, after anastomosis, the vein is kinking, artery you cannot redo, vein is already kinking. So we should make sure that how we can manage this. Sometimes you can do some anchoring sutures, make sure that the artery and vein sits properly, especially in the neck. When you do the anastomosis, turning the neck to the other side, and once you turn back the neck and remove the shoulder bag, your anastomosis become totally loose, and it may be hanging and giving a lot of kink. So you should be careful and managing it before doing this anastomosis. Avoid the drain tips near the anastomosis. And very important is try to cover the pedicle, especially in the limbs where there is anastomosis beyond the zone of injury and you have nothing to cover there. It's very important, where the blowouts can be detrimental to the flap. At maybe around 10 days, 12 days, you might still lose the flap. Don't forget to ligate the second vein. You're doing only one vein. Sometimes you have to end up and re-explore and ligate the second vein, and it becomes a important problem. Good hemostasis is a key. Leaving some gauzes inside at the anastomotic site. You need to, don't forget losing these gauzes there, and proper immobilization post-operatively. Post-operatively, elevation position is very important. See this picture, the big LD done, and it's very difficult to position the limb because the medial end has to be above. And unless until you position this limb, you might end up losing the flap or the distal part of the flap, which is very key. Immobilization, elevation, and always monitor the flap well so that you should not lose an opportunity to re-explore, because re-exploration is the only one-time chance you get to salvage a dying flap. Make sure that there are no hematoma compressing the pedicle, and make sure that hemodynamic stability is good in the post-operative period, and replenish blood loss. Even though we want a hemoglobin around 9 is ideal, but always make sure that patient is not too losing too much of blood there. And think of secondary hemorrhage, blowouts, and maybe leaks. You should not have any go on re-exploring anything you want to see. Better to go to the OT and see back rather than wait and watch. So coping up, when I go back to the same slide, we are ready to do a second surgery. Sometimes you can see the incision here. It's a ALT tried on both sides, no pedicle possible, no skin pedicle, and you have to do an intraoperative decision of doing a groin flap. So you need to be ready to open mind and go back and try to do the things which is possible. And sometimes immediately you do, this is a case of anterior cranial fossa skull defect with an anterior cranial fossa complete defect of the one-sided ACF floor, which brain and ACF leak is there. Planned a ALT with a skin paddle, did a vein graft to the facial artery in the cheek area, but we couldn't salvage because on table we had no vascularity, was not coming to the flap. Even after about 7-8 hours of surgery, you have to have an open mind, go back. This is the second flap done soon after that. It's a rectus flap done with a venous pedicle with a skin paddle, and this is done. So be open up, try to go back, and we have to salvage a flap means we should be ready for it. Subsequent free flap, sometimes this is a defect which needed a flap. We did a gracilis because thinking the defect is less. As I mentioned, because of the poking bones, the flap ended in a failure, and we have to do a LD flap later. Thank you for patient hearing. Sorry for the technical glitches.
Thank you, sir. Now I would like to invite Dr. Prashant Puranik to give the last topic of the talk on last topic of the day on perfurosome concept.
Are you able to see my screen?
Yes, sir. Yes, sir. It's visible.
Is it full screen?
Yes, sir. Yes, sir.
Okay. Is my voice audible?
Yes, sir.
Okay. Thank you. I think I would like to speak about the perfurosome concept and its impact on microsurgery advances. We have had a very comprehensive discussion from flap planning to various common flaps that are used, about principles of onco reconstruction, breast reconstruction, and microvascular complications and its management. So we are in an age era of digital revolution, where I think one of the examples that we can give is about the present day SIM card. We can see that the SIM cards are getting smaller in size, and the mobile's screen guard is increasing. So similarly, we have evolution in all aspects of healthcare, also like in the surgical specialty, from the past to present to future. So we're going to have more and more technology and innovations and interferences to make the patient care better. But any advancement will have will look into the basic concepts and how each of them can be improvised. And we all know that reconstructive surgery, the flap is one of the basic part of plastic surgical training. And any flap will have three components, like flap harvest, planning and fabrication, and anastomosis. And about each of these parts aspect, there have been elaborate talks till now. And looking into see how the future would be, it would be better to understand how things have been from the past to present. So if we just see, the microsurgery was first, the term first microsurgery was done in 1960. That was on a canine carotid artery. And then the super microsurgery was done in 1998, almost at a gap of 38 years. And this was using paraumbilical perforators. And we had a first panel on microsurgery way back in 1970, and a first panel on super microsurgery, and with consensus of definition on super microsurgery in 2010, almost 40 years gap. And the first free flap was done in 1974, and the first perforator-based free flap was done in 1995. So there is movement, there is advancement of microsurgery from super microsurgery. And all along this, what has progressed is the understanding of the perforators and how the flaps have been based on perforator, and the anastomosis are being done on perforator. As discussed before, one of the problems with flap could be because the perforator was injured or the perforator was not assessed properly. And so the perforator understanding is very important part of microsurgical practice. So previously we had angiosome concept. This was described by Taylor in 1987. That led to development of array of flaps, and the microsurgery became major force in reconstructive surgery. So at present, microsurgery can cater to very broad spectrum of applications, and it can address a wide variety of defects with high success rate. And compared to super microsurgery, it provides lesser instrumental needs and easier access among our colleagues and support groups, and we have wider learning platforms. So, but there has been advancement over last 10 to 15 years with understanding of perfurosome concept. So because of understanding of perfurosome concept, we are now experiencing a very wide range of perforator flaps, and these perforator flaps have in turn evolved to give the basis for super microsurgery. But this comes at a cost. The cost is it requires a higher learning skills, higher skills, and a longer learning curve compared to regular microsurgical techniques. But it provides improved donor morbidity, and it can provide wider applications. So now we have a lot of perforator flaps like MSAP flap, groin flap, ALT flap, and it has also led to perforator anastomosis, advancement in tip replants, diabetic foot. We are having newer donor areas, and we can have freestyle design. And it has led us to plan and execute multiple chimerism by understanding this concept. And also it has led to newer planes of elevation, like we can try to elevate our flap This was done with Dr. Aditya. We can try to elevate this flap above the superficial fascia, making this flap homogeneously thin with very minimal morbidity. And we can get very thin flaps, and we can do perforated to perforator anastomosis. These may be advanced applications, but perforated concept is very important because nowadays we have a shift towards using single perforator based flaps, let it be DF flap or ELT flap, and knowledge of each individual perforator vascular anatomy is very important. Previously, we would try to understand the anatomy of source artery, and we also need to understand the anatomy of the perforator. So similar to angiosome, we have perfurosome concept. So there have been 4 main principles with the perfurosome concept, and this is a very good article by Michael Saint in PRS 2009, which describes 4 principles of perforator concept. And one of the first concept is that there is a dense network of vessels around the perforator. In the extremity, they tend to become lesser in caliber, and there is extensive branching, which will anastomose with surrounding perforator. Similar to angiosome concept, we have direct linking vessels and also very thin caliber indirect linking vessels. So since a perforator flap will have high perfusion pressure, because the through a small tubular structure, a large volume of blood is flowing, it opens up multiple direct and indirect linking vessels, and perfusion of other perfurosomes can significantly improve. And these perfurosomes can be connected to one another by direct linking vessels as shown previously, or with subdermal plexus. And the subdermal plexus continuity forms the basis of suprafacial flaps like groin flap or superficial based thin flaps or even DF flaps also. The second principle is that there is a particular pattern in which the perforators are connected. So if you understand the pattern in which the perforators are connected, we can design the flaps in a particular way. So this orientation of linking vessels determines the orientation of the vascular flow. In the sense, with extrapolating this principle, it is seen that the perforators are connected by in transverse direction in the trunk, in the chest wall, in the abdomen, and in the back, they're connected in the transverse fashion. And in the extremity, they are connected in vertical fashion. So this can have implications in planning the flap. So this is one of the dye studies that was done, which shows that the linking vessels are perpendicular in the extremities. One more from the study from the leg and from the posterior thigh. Whereas in the abdomen, the linking vessels are more transverse. So as a result, we have flaps which are more transversely oriented, like DF flap, or in the proximal extremity, like in the creases, like tug flap or groin flap, where the orientation of these vessels is transverse. So the flaps are planned mainly transversely. So the third principle is that there is preferential filling of perfurosome from perforators of the same source artery. Elaborating to ELT flap, if there's there are 2 perforators from descending branch of lateral circumflex femoral artery, they are supposed to get filled first. Then the perforators from anteromedial thigh perforator can be filled. So this is one of the principles that can be applied for when we are planning for perforator-based flap. And the fourth principle is that in the middle of the extremity, the perforator runs in both the direction, but towards the joint, the perforator runs away from the joint. So all these principles have been applied to various aspects to design newer flaps, and it can help us in making some good clinical decisions during surgery. So with this understanding, there have been multiple areas of application, like they have been applied for breast reconstruction, where initially heart-run perfusion came, then we have Holmes perfusion zones. Now there have been many newer articles where they have tried to even further subdivide the abdominal perfusion zones into almost like 6 different segments, and each of them being allocated a particular grading, and this depends on whether the perforator is from medial row or lateral row. All these are attempts to improve the perfusion of the flap, decrease flap related complications, and at the same time reduce the donor site morbidity. What has led to this perfurosome concept is that what we clinically see nowadays is a wide explosion of perforator flaps, like groin flap, sural artery perforator flap, or profound artery perforator flap. and the thinning of conventional flaps. Like previously, we used to have regular ALT. Now it's being done in superficial fashion. Groin flap is done in superficial plane like skip flap. Tram flap has evolved into DF flap. Perforator anastomosis and lymphatic studies have further evolved. So all these aspects can be we can try to approach and we can try to discuss at our cadaveric dissection course. And I think we have had a very comprehensive talks about each aspects of reconstruction. And this is a hands-on course where we have about 4 dissectors per body, and we have minimum two faculty per cadaver. And we have a very good multimedia projector on this. Initially, demo will be done by the faculty, and we can have didactic lectures in the skill lab. So it also provides an ample opportunity to practice many of the other unconventional flaps, and we can discuss various clinical scenarios. And this we are having it on March 28 and 29. So the cadaveric studies also gives insights into vascularity of various areas. We can do anatomical dissections like hand, foot. We can try to understand various other flaps, and we can try to understand other flaps which we may not be able to do in regular practice, like it could be a iliac flap or scapula flap. So this will help us in improving the overall repertoire of our regular flaps. So these are the flaps that we had dissected in the last dissection course. We had a very comprehensive list of flaps that were covered last time. So this time also we anticipate from our expert faculty same amount of dedication towards this flap course, and we all hope that we'll have a great flap dissection course this time at MS Ramaya Skill Lab. Thank you very much. Dr. Aditya, are there any questions?
Thank you, sir. There are some questions from delegates. One is, will doctor provide any notes before course start?
Yeah, we do provide some presentations and some of the videos of the commonly done procedures, and they will be sent through the mail.
Okay.
For almost all the common procedures that will be done, we will be providing academic material.
And the next question is, if I have not done any cadaveric course before, can I still participate in this program?
Yes, you can still participate in this program.
Okay, sir. I would like to thank all speakers and delegates who attended this webinar. And I am happy to share that more than 150 members have been attending this webinar. And now I would like to Dr. Prashant, sir, would you take over and give a thanks note to conclude the meeting?
I think we had a very comprehensive session today to showcase what all aspects of to showcase all the aspects of microsurgery, from basics of flap planning to understanding about all the common flaps, about onco reconstruction principles in great detail, and also about the upcoming topics like breast reconstruction. And we had a very comprehensive and detailed talk on managing complications, because I think complications is what lets people to venture into difficult aspect of this microsurgery. It has been a very comprehensive and very detailed course. I thank all the faculty. They have done a fantastic job. And I think I thank Dr. Shant Kumar, Dr. Aditya, Suresh, for moderating this session. And I thank all the delegates. I look forward to each of them so that we will have a very interactive and in-depth study about all the flaps. And we hope we will have a very fruitful cadaveric dissection course. Any further queries, we will be willing to answer.
Thank you, sir. Does anybody have any queries you can ask?
Nothing.
Otherwise, we can conclude the session, I think.
Yeah. Thank you, everybody. Good night.
Thank
you. Bye. Thank you.
Thank you, everyone. Thank you. Good night. Good night, sir.